All right, so then I would like to invite next Dr. Junhao Wen, one of the first CIMBID recruits who will talk to us about, assistant professor in the Department of Radiology, who will talk to us about his exciting research in AI, genetics, and neuroimaging. Junhao, thank you.
Hi, everyone. Thank you very much. So yeah, my name is Junhao Wen, and I'm currently an assistant professor at the radiology department, and I might be the newest recruitment of the CIMBID Center, so I'm very excited to be part of the great initiative. So for today, I'm just gonna discuss some our current research from my lab that aligns with the overall scientific interest of the center. So I think we all agree as a machine learner or computer scientist, AI and machine learning has been trying to revolutionize biomedicine. But I want to take one step back to think about reproducibility of those AI and machine learning models. And because right now it's a very hot topic, and a lot of people want to use AI and machine learning models in our own biomedical research. But the point that I want to highlight is that a lot of people, researchers have been trying to seek for the state of the art of AI machine learning models, but there are a lot of tricks that we need to be aware, or we need to collaborate with experts from different domains. So one of the study we have been doing here is try to benchmark to provide an unbiased classification performance to predict Alzheimer's disease patients from imaging data. Using publicly available data sets in this paper, we have identified from the previous literature there might be a large proportion of the studies who report very high accuracy, but the accuracy is not reliable, which we call data leakage or double dipping. And then we use convolutional neural network, try to benchmark the overall classification performance to predict Alzheimer's disease from health control to mild cognitive decline, and then to the disease of onset of Alzheimer's disease. Just to highlight, I think it's very also important to be overall very positive with AI and machine learning in biomedicine, but also try to be, I think very objectivity and reproducibility is very important. Another branch of research we have been interested in doing is to use AI and machine learning to understand disease heterogeneity, specifically in Alzheimer's disease and aging. And of course, the foundation of the biomedical data we have been using is imaging. But of course, we have been trying to extend from imaging to other omics data like genetics. The papers here I'm trying to present a little bit here is we developed several different what we call weakly supervised learning methods to try to understand disease heterogeneity, basically find those disease subtypes of Alzheimer's disease patients based on the MRI data, imaging data. And mathematically speaking, this is a clustering problem. Of course, the most common approach is going to be apply unsupervised learning like k-means, for example. Find, I don't know, k subtypes of Alzheimer's disease patients. Alternatively, we have been trying to model this disease heterogeneity from another perspective, what we call weakly supervised learning. The key innovation here is we use the health control population as a reference domain. And then we model what we call a 1-to-k median from the health control patients to the health control stage to the patient stage. In that way, hopefully, we try to remove those pathologically unrelated variants and focusing only on the imaging variants that specifically link to the underlying imaging variants in the Alzheimer's disease patients. And like I mentioned, the primary research interest of our group is brain imaging, like neuroimaging data, but also we have been trying to extend this scope to other omics data like genetics. In our recent research, we have been using brain imaging genetics, trying to understand human aging and disease. In this work, we have using multi-model brain MRI data from UK Biobank to derive what we call biological age gap. Basically, it's a regression model. You can fit your AI machine learning model with whatever data, like brain imaging data or genetic data, proteomics data, etc., to predict your calendar age. And then you use the AI predict age minus your calendar age, the difference between those two ages. That's what we call biological age. And then you can use those biomarkers to digitize or quantify one patient like overall like brain aging health or other organ health, which I will show later. That's what I mean, the multi-organ aging clocks here. So the previous slide, we have been conceptualized the idea of aging clock for the brain using like brain MRI data. Here we extend this to different organ systems using like the different clinical variable from different organs. And another project we have been focusing on is like to go beyond the brain, like to look at the cross-organ interconnection between different human organ systems. In this paper, we have looked using leverage large-scale MRI data from the heart, from the brain, and also IOCT data, and using machine learning AI, try to derive some data-driven imaging features at the three different organs, and link them by imaging, genetics, and also plasma proteomics data to provide more molecular insights for the cross-organ interactions. Yeah, that's the main topic of the research in the lab, and I'm very excited to keep the collaborative effort with all the colleagues at the CIMBID Center, but also from other institutes at Columbia. Thank you very much. Yeah, I'm very happy to answer any questions. Thank you.
Thank you so much, Junhao. Very exciting research. And now I'd like to welcome Dr. Sachin Jambawalikar, who will talk to us about multimodal methodologies for medical image analysis and also some of the Herculean efforts to put up infrastructure. Thank you.
Left, right? The green button. Oh. Thank you, Despina, for inviting me to this CIMBID launch and also being part of CIMBID as a Director of Research Informatics. Chief of Medical Physics here, working with radiologists, as the theme has been collaboration with everybody. A lot of my research efforts have been through collaboration with our radiology partners, our engineering partners, groups. A little bit about multimodal analysis. We have done work in multimodal imaging modality and also multimodal combination of imaging with radiological reports, imaging with pathology data. Some early work I'll present here. One of the early works was multimodal work was more of imaging, trying to predict oncotype DX, radiological imaging data, trying to predict breast cancer recurrence using oncotype. Can we predict the oncotype DX recurrence score? So this was our early kind of multimodal work where we use imaging to predict genomic data, kind of. Another work which we have collaborated with, or my lab has collaborated with, is with the engineering team in mechanical engineering to do preterm birth prediction using segmentation of transvaginal ultrasound images in a multi-class way, which was just published. The standard of care for preterm birth is just that segment which you see, the cervical length. We were able to extract anterior, posterior cervix accurate segmentation around 86% sensitivity specificity of for these kind of segmentations. Also, one of the things we are trying to do is, besides just the cervical length, can we have additional features which can predict preterm birth? Because the cervix is not just the length; it's a softness of the cervix. It's a three-dimensional entity, right? So how do we do that? We are generating these kind of segmentation features. The mechanical engineering team is generating tissue features, and then we have EHR data which we are integrating together as well. Another thing that this can be used in real world is with this segmentation we applied it to a cine data, and you can see that you can automatically come up with an ultrasound slice, where even if it's not a trained expert, we could get a good region where we can acquire the ultrasound image. Going forward, we are with our the flywheel platform and CIMBID, we are trying to integrate all these features, imaging features, RedCap features. We have an IRB for looking at data for 20 years for this kind of data, and also adding some other tissue features like shear wave elastography and aspiration, which the mechanical engineering team is getting from this data as well, and integrating that together to do a multimodal classification for preterm birth prediction. Another work is with one of our chest radiologists was to try to see if we can look at lung nodules, which Despina mentioned some time back, where AI does assist a lot. So look at lung nodules at the macroscopic level, like CT data, or even at the microscopic level, like digital pathology data. And we had done some work also to find that nodules, AI works well if you give also information about the environment of the nodule, like if the nodule is in a fibrotic environment or a non-fibrotic environment. One of the things we found in both CT and pathology data was that if the nodule is in a fibrotic environment, there is a high chance of it to become cancerous, like 10% chance for a small nodule to become cancerous as compared to 1% in a non-fibrotic environment. So this is some of the work we have done as well. Lastly, we have this is a real multimodal integration where we have this new Gen AI models, vision language models, which we are working on. This is a collaboration work with BU, one of our collaborators, Kavya and Batmanglik. This is, they have a pre-trained model using around 20,000 mammograms and reports. Locally, we are validating this model using 50,000 mammogram data and radiology reports. And also you can see that based on the reports, you are able to predict that in the heat map, where there'll be calcification or where will be the masses. So it's a weakly supervised model which learns from the reports where those pathologies or indicators of cancer could be. So I'm really excited about this work. Going forward, again, this platform which we are launching with CIMBID would be available for us and also for working with our industry partners to do science at this kind of AI models at scale. Also, we'll have available curated multimodal data sets. And this platform is a very customizable model platform for us. So you could even do, as Naomi mentioned about federated learning, we could do federated learning work with this platform as well, and working on foundational models as well. Also, it allows us, one of the key challenges in radiology is like we collaborate with the radiologists. Every research group has a different viewer platform to look at the imaging data, because radiologists want to look at the data, look at, provide annotations, things like that. Here, Flywheel also provides you with a reader study interface where they can annotate and they can validate the algorithms by looking at the results and say, oh, this is interpretable or not interpretable. Lastly, one of the cool things I hope to see with this launch is, besides academic research, also industry partnerships with us to do validate their algorithms with our local multimodal data and generate clinically relevant tools for patient care. So with that, I'll stop and. Any questions?
Maybe people need more coffee to ask questions. Don't forget there's coffee in the back and water, and then later we're going to have lunch downstairs and more goodies in that sense. So with that, I'd like to invite Sam Payev-Bash, also assistant professor and associate professor in the Department of Radiology and the director of Clinical Translation and Innovation, to give us a bit of a highlight of his research.
All right. Good morning, everyone. Thanks, Despina. Thank you all for coming. Exciting times. So I'm a neuroradiologist by training. I'm also a clinician scientist. And I would like to talk a little bit about our research project in stroke imaging and a little bit about CIMBID vision and mission for clinical translation and innovation. So why do I personally care about a stroke? Almost every 40 seconds, someone in USA has a stroke. Every 3 minutes, somebody dies of a stroke. That's a total of over 800,000 people who suffer from a stroke each year in US, with over $60 billion cost for our healthcare system these days. And it is the leading cause of serious long-term disability. Now, a stroke comes in two flavors. One is that you do not have enough blood coming to your brain, ischemic stroke, or there is too much blood. There is like a bleeding into a stroke, what we call hemorrhagic stroke or intracerebral hemorrhage. So how does imaging help with the stroke treatment workflow and paradigm? First and foremost is the diagnosis. It's very important to diagnose stroke as fast as possible. It's time sensitive, and every minute that we lose, some part of the brain is lost. So time is brain. Now, we already have some tools and AI tools that can help us expedite and automate the identification of the stroke, either ischemic or hemorrhagic. But the two other areas, prognostication and treatment guidance, are now areas of active research. So this is something that is like more important in the area of active research in my lab. Prognostication, it's about risk-based treatment guidance, knowing who's gonna get worse, who's gonna do fine, and based on that, you know how to escalate or de-escalate the next step of the treatment. The other thing is about the treatment guidance. For example, for ischemic stroke, it's now over 3 decades that we have found like treatments to open up like the clot. So we know that there is not enough blood. We have some treatments for them to go there and try to either do the thrombectomy, open up the large vessel, or do the IV thrombolysis. But what about next? It's the next that especially the imaging can help guide the treatment. What comes after reperfusion? How can we identify and personalize treatment looking into neuroregenerative and neuroprotective treatments after that? And that's the area that is really the focus of the CIMBID, is to combine the imaging and non-imaging information and try to offer personalized, targeted treatment, moving beyond one-size-fits-all treatment options. So some of the projects that we have done in my research, as I mentioned, was like prognostication in large vessel occlusion stroke. What we did was trying to get the CT angiogram of the patients, extract imaging information that we call radiomics from them, and try to use them to predict outcome like a week and 3 months after stroke. Now, remember, as we talk about harnessing information from images, this goes to really the core of this project. A radiologist will look at these images and will tell you whether or not there is large vessel occlusion. But there is not really that much that I can tell you how it's gonna happen like a week or 3 months later. It's just like not something that we can catch with eyes. And that is the kind of thing that computer vision can really help us extract from these information. So here, we are showing how using the radiomics, we could predict the outcome at discharge and long-term 3-month outcome. And we are showing how we can add clinical information and treatment information to gradually improve that prediction. So if you think about it, these are all information that we will have access to within the first 24 hours. This is a patient who comes in. We give the CT angiogram to our radiomics pipeline. We will tell the pipeline how this patient is 80-year-old, has diabetes, so on and so forth. And this was what happened after reperfusion. And the program will tell you, this is how it's gonna the patient do like 1 week later. This is how it's gonna do 3 months later. And we can tailor treatment based on that. We use this to, for example, predict the collateral status. If you guys look at these, you can see how like the image on the A has like, is a little bit darker on one side, whereas on C, it's like kind of symmetric. This is the collateral status. This is something that is helpful for clinician in terms of prognostication, like what are the reserve of the patient who has like a large vessel occlusion. So we trained a radiomics model to predict that. And you can see that it does like fairly when we compare it to neuroradiologists. I was one of them, actually. But what was more important was that if you look at it, the prediction of the collateral gave us more meaningful prognostication than the one that we were using as consensus to train the model. So this was very interesting to me, was because we were using neuroradiologists to tell us what they think about the collateral status. And we trained the model to make that prediction. Interestingly enough, what the model predicted as collateral was more strongly associated with outcome with what the neuroradiologist said. So somewhere down the line, the model was like extracting information that turned out to be more clinically relevant than the information that we as neuroradiologists were using to train the model to begin with. Now, we shared our data online. Moving on, so radiomics basically use preset formula to extract some of the features, and we can combine them to like a conventional machine learning. With deep learning, we can fully automate that process. So this is like moving on. If you guys remember from the earlier slide, you would see that there was some pre-processing that we did for extraction of the radiomics. With deep learning, this is an end-to-end automated pipeline. It is thinking about, you have that image, get that image and tell me what's going to happen. So that's our work. And as you can see, again, by adding the clinical and treatment information, we can improve the prognostication. So now, how can deploying AI improve the ischemic stroke treatment? As I mentioned, it can expedite detection of the treatment. It can expedite treatment triage. It can, as I mentioned, every minute counts after a stroke. But it can also go above and beyond. Again, it can also, if a patient comes in, and this is like one of the problems that we have in the clinic, and we don't exactly know what was the onset of the stroke. The patient was found down on the street. You know it's a stroke, but you just don't know when it happened. So these are like basically the ongoing project in my lab. One is to look at the images and tell me, did it happen 6 hours ago? Did it happen 24 hours ago? And it matters because beyond a certain time point, we know that the treatments that we have not going to be beneficial, it will actually be detrimental to patient. And as I mentioned, also moving the treatment beyond and after reperfusion. Really something that is important for me is that especially the clinical trials that came last year shows that there is benefit in reperfusion even in large core infarct. So the way I joke about it is that if a patient comes in and has a stroke, as long as there is a head connected to the body, the neurointerventional is going to go after it and open the clot. That's literally where the stroke paradigm is these days. But we know that still there are these futile reperfusions. And that is really where the treatment should go. So that is what is important for us, is to understand, okay, we know that we're going to open that occlusion. What's going to happen next? And if we know already that although we open this, there is a good chance that this patient will have worse outcome, those are the treatment, excuse me, those are the patients who will need to go for the next step for neuroprotective, neuroregenerative information. Now, intracerebral hemorrhage, it's only 15% of all the strokes, but it caused half of the disability and half of the death related to a stroke. So that's why I would call intracerebral hemorrhage or hemorrhagic stroke the deadliest and most disabling form of stroke. And unlike ischemic stroke, really treatment is not really that great right now. If it is too large and if it's like close to surface of the brain, we know that we can go and evacuate that blood. But other than that, our best bet is to prevent worsening of the patient situation. Some of these patients are at risk of hematoma expansion. In other words, that the bleed get bigger. Some of them are at risk of swelling or perihematoma edema getting worse. Now, there are a lot of trials going on. There is, this is just like a handful of them that I listed there, who have targeted hematoma expansion and perihematoma edema, swelling around the brain, for the treatment. Now, the reason why I put that second column is because there have been millions of dollars spent to treat these patients. For the most part, they couldn't get any results, and then the post hoc analysis showed that, oh, there were like subset that were, could have benefit, mostly because they just treat everybody who comes in based on the size of the hematoma. They have no clue who's gonna have hematoma expansion or who doesn't. We know that only 30% of patients have hematoma expansion. We know that hematoma swelling around the brain, excuse me, is different from one patient to another. So that is the focus of my research, is to identify patients for targeted treatment. So in this study, we shows that, again, using radiomics that from the brain bleed, that bright spot that you guys see there, can give us information about how the patient's going to do well, and who's going to have who's going to do well, who's not going to do well 3 months later. We showed that if we combine the information from the bleed with the swelling around it or edema, the risk stratification is going to get better. We showed that we can use those information to predict which hematoma gonna get bigger, hematoma expansion. And we moved beyond that, we moved to use deep learning to automate the whole process. So this is, again, as I mentioned, for the ischemic stroke, is about get the head CT and let the pipeline do the whole work, basically. Go straight up and tell us who's gonna have hematoma expansion and who's not going to have hematoma expansion. And you see on the title of the paper, we said uncertainty aware. And it's kind of circles back to what John Ho was saying about generalizability of the model. So at this point, we really want to deploy our models for clinical practice. And what we learned is that accuracy alone is not enough. We are trying to quantify uncertainty of the model. In other words, not just tell us if the patient's gonna have bigger bleed or a smaller bleed. Tell us how confident are you in your prediction. Moreover, make it robust. If there are noises in the image, try to still do better. Make it generalizable. So, for example, what we figured was that when we shared our model with our colleagues in Berlin, the model, dropped the prediction. And we looked into it and we realized, oh my God, like the hematomas that they have is almost twice larger than the ones that we have. So that's generalizability. That's about I have 1,000 head CTs here. I'm going to train the model, but I have to also make sure that first my model tell me how certain they are about the prediction, and make sure that if I send it somewhere else, the images are noisier, the images are, like different, what we call domain shift, it still can give us some, prediction, because we want to rely on them for clinical diagnosis. So this is what we did for robustness. We use adversarial training. So this is basically means that we try to also, like in the training process, we added some noise which was specifically crafted to fool the system, and in this way made it more robust. So where are we going next in terms of the hemorrhagic stroke? Automated identification of ICH. There are commercial products for this. We can quantify ICH. This is important because that 30 ml is the right now the criteria for doing intervention and evacuation. And then the area of active research for my lab is to identify patients who are at risk of hematoma expansion, finding those who are at risk of neurological deterioration, and also those who would benefit from drain placement. Despina show you guys kind of like a slide like this, and it's kind of pivoting towards what our goal is in terms of the clinical translation and innovation. So you guys already heard most of the AI tools out there are focused on radiology, and a lot of them know radiology because no radiologists are the smartest people anyway. So now when we talk about that, there are a lot of commercial products out there, for example, for automated detection of ICH, automated detection of pulmonary nodule. That's good. That can expedite our process. And that's something that industry can do very well. They can get the data from anywhere. But how about academic medical centers? What is it that, for example, Columbia can offer that others cannot do it? We have access to curated data about the patients, not just for making the diagnosis, but also to tell them what's going to happen next. In addition, if we are moving toward the like AI-based tools that can tell us how the patient are going to do well or try to guide treatment, we need to be able to continuously adapt and retrain that model. Hemorrhage in the brain looked like that bright spot since 4 or 5 decades ago when CT was invented. ICH is gonna look the same no matter what. But how the patients with ICH gonna do will evolve over time, and that is why if ever, once the industry gets to the point that try to make models for precision treatment, it would only work with continuous partnership with centers like Columbia, because they should adapt their models based on evolving treatments. The ICH treatment had evolved over the last 40 years. So did ischemic stroke, and that's why we are at the best place to make these models work. And then also going above and beyond, we have the data for integration of the radiomics, proteomics, genomics to make the really personalized treatment, so moving above one size fit all. And eventually some of the things that are, we're very interested in are also opportunistic screening and data extraction. For example, if the patient had an abdomen CT, we can use that information and give you like a equivalent of the DEXA scan. What I've heard is that now they're actually they have commercialized it because every patient, like say above the age of 65, should get a DEXA. So imagine that we run this program in all our abdomen CT, and for those patients who are above the 65, we'll tell them, hey, you know what, you get a free DEXA on the house. We probably can also bill for it, but that's, like basically the goal of it. We can also use this, for example, chest CT quantification of coronary calcification. These are all the areas that we do see, like a future partnership. So with that, thank you so much. And I can take any questions, and I'm so sorry if I went way beyond the time limit. I got that card of 1 minute or so.
Hi. Sorry. Thank you for the great talk. So I had a question because every time I see neural networks and predictions of outcome, I'm wondering, neural networks have that very sneaky way of finding what you are asking them to find by, for example, reading the name of the hospital on the X-ray, or using the grain of the image to judge the price of the machine that took it, and which is linked to outcome. So how much of a focus is it in your experiments? And maybe also a follow-up and related question is, once you start taking decisions based on that, the outcome is going to be affected compared to, just we have recorded data right now in those data banks that everyone has access to now. And no one took decision based on those hidden data, but now it's going to change. So how is it going to change your way of thinking about it?
So one of the ways that they're now using it is a little bit of like an explainable AI. So get us some insight in terms of how the AI had made that decision. So we use that to, like highlight the areas that were important. That is, like decent, but we also, that goes back to the idea of like a generalizability and certainty quantification, because that's really what we've seen is that, as you mentioned, like the things that, like the neural network took into account in terms of making that, like prediction is very much based on what we use for training or, so that is where I believe that the certainty quantification can help us to tell us, hey, I told you it's gonna do better or worse, but I'm not really confident if this is applicable to, like the case that I'm looking at right now. The other one is that, of course, we are very data greedy. Specifically, all my projects are multicentric. We really want to collaborate with large health networks that can give us information not just from tertiary centers, but also from the community hospitals. So at Columbia, for example, it's not just the Milstein Hospital. We also have Allen and Lawrence. We, same with Cornell. NYP, if you look at it, has like a lot of ancillary hospitals, and they use different scanners. They're serving different patient populations. So those are the tricks that we are trying to use to make sure that it's generalizable, and then also use explainable AI to make sure that the decision made kind of makes sense. You always need to have a human co-pilot.
All right, thanks.
Thank you, Sam. That was exciting research and a great example of how much information is in the imaging data that are acquired routinely, paid for by insurance, and nobody ever used for any reason. And I think it's very easy in some ways to use artificial intelligence. It reminds me, when I was still a postdoc, more than 15 years ago, we had a very visionary department chair. If you're in the field, you may remember Arnick Bryan, who's now retired. And he used to say, people were asking at that time, will computers, they didn't call it AI, will computers replace radiologists? And he was very calm about it. He used to say, computers will not replace radiologists, but radiologists with computers will replace radiologists without computers. And I think Sam is a great example of that kind of radiologist that's taking the job of the other radiologist, right? And so with that, I'd like to welcome a great colleague and friend, Jeff Goldsmith, Associate Dean for Data Science at the Mailman School of Public Health and Associate Director for CIMBID, to talk to us about his exciting research and his role in this ecosystem. Thank you, Jeff.
Thank you. Make sure I know how this works. So I'm thrilled to be here. I'm going to be talking about biostatistics at CIMBID, sort of generally speaking, not just p-values and power calculations. Now, don't get worried. There will still be p-values and power calculations, but we're going to do other stuff as well. If you're sort of following along in the program, there's a long title for what my talk is, not just biostatistics at CIMBID, advanced functional data analysis for et cetera. And the reason for that is that in biostatistics, the sort of umbrella that shapes my work is this field of functional data analysis. And as I get into what I'm talking about today, it's going to be less like a bunch of specific things sort of pointed in the same direction, like we've seen a great examples already. It's going to be like 3 different projects that are pointed in different directions that are increasingly less imaging focused, but are sort of intended today to be a call for collaboration. Like, I would love for somebody to see something and say, well, that looks neat. Let's try to figure out how we can work together on this. As I was thinking about what to talk about today, I was reflecting way back in the day. I had imaging in my dissertation in biostatistics. We tried to estimate the extent of the colon using SPECT imaging. We used features extracted from diffusion tensor imaging to predict multiple sclerosis outcomes in a couple of different ways. And the reason that I sort of thought about this is, at the time, this was like cutting edge stuff. And also, I promise you, it was not that long ago, but it's like looking at something from the Stone Age. It's like it belongs in a museum. Like there's no way that you would do anything like this now. But what's exciting about it, for me, is not just like the passage of time and like, oh gosh, the passage of time. But it's sort of like, this is an exciting day to think about what's possible now, to reflect on where we are now compared to where we were a few years ago. The launch of CIMBID, in what we're sort of all calling challenging times, but the launch of CIMBID, I think, is genuinely exciting to bring together a great research community, a lot of data resources, and to think optimistically about what can change and how quickly it can change. And so I'm actually genuinely excited. So like I say, I'm going to talk about 3 individual projects that are increasingly less imaging oriented. The first of these, I think, is actually genuinely imaging in nature. So a couple of years ago, I worked on a project, intensity warping for multi-site MRI harmonization. And to give you a sense of what the problem is, on the left side, I'm looking at voxel intensities for a single person. This is one person who was scanned twice at 7 locations, went in the scanner, left the scanner, went in the scanner, left the scanner, and then moved around. And so you'll see here, all of that sort of shift in the left-hand panel, that is just scanner effects. That has nothing to do with differences in who the person is or the patient or the biology. It's in the scanner, out of the scanner. And what you would hope to see if you're going to bring together data sets like this, if you're going to bring together data resources from multiple scanners, is some way of putting all of this into a single framework. And so this intensity warping for multi-site MRI harmonization sort of took everything on the left-hand side and made it look like the right-hand side. We were able to sort of remove that scanner variability. We had a follow-up data set in this where 10 participants were scanned on 2 different scanners in the same location. So 10 patients at Penn Medicine were scanned on 2 different scanners. And we sort of figured out, like, what do you need to do if you're going to take an image acquired on one scanner and make it look like it was acquired on a different scanner. And we compared 3 different approaches, histogram matching, white stripe, and our proposed approach. And the sort of bottom panel there, where underneath mica you see almost nothing, we've removed effectively all of the scanner variability, right? So we were able to take care of that piece. So here, when we're sort of thinking about bringing together a lot of these different data resources, keeping in mind the sort of scanner effects, the batch effects, the other things that can creep into the underlying data and affect things like summaries that have to do with lesion volume or gray matter volume or other things like this, keeping that in mind and trying to account for it in a principled way is going to be important. Second project, which is still, I would argue, imaging related, but getting farther afield, is adaptive smoothing. So I have a colleague in neuroscience at Case Western who is very interested in understanding neural dynamics and the sort of drivers of motor control. And he has a mouse who will hear an auditory cue and then reach for a food pellet. And he's sort of trained to do things in this way. And while this is happening, there's an electrical probe in the motor cortex sort of picking up individual neurons and trying to see sort of what happens. And the data that comes out of it, we would argue, is noisy, but definitely shows some signals. So you sort of, if you look, you can see just a little bit of time after the cue, you go from sort of background noise to a lot of activity. And our goal here is to do some version of feature extraction. We want to understand what's actually happening underneath the sort of noisy signals in a way that accounts for not a lot is happening, and then there's a very sharp jump, and then sort of a smooth decline afterwards. And so this sort of adaptive smoothing, the underlying idea is to say, we want to get the amount of smoothing that you're getting from a noisy feature, we want to get that right. It should be pretty smooth, but then allow for something to change very quickly and then return to smoothness afterwards. And that's the sort of piece that we see here in the top row. You sort of get the version that we have here is able to detect very steep changes in underlying signals, followed by relatively gentle declines. And the reason I sort of say this is not imaging yet, but we're interested in that kind of collaboration. We've talked with folks who are looking, for example, at task-based fMRI, who are trying to understand where things are changing in time. We've looked at EEG signals in a variety of clinical settings where you expect there to be some change that happens at a particular point, but you're not exactly sure what it's going to be. So this sort of adaptive smoothing piece is what we're interested in. Now, the last thing that I want to talk about in my last 2 minutes is nothing yet to do with imaging, but I think plausibly will go in this direction. And this is work that I've done with folks in environmental health and epidemiology, and it's to incorporate menstrual cycle day into a variety of analyses. And so, for example, my colleague Lauren Houghton in epidemiology has looked at the role of hormones as predictors of breast cancer risk. And to that analysis, we added cycle day as a marker. And what we found, in fact, is that certain hormones have different effects early in the menstrual cycle versus late in the menstrual cycle. Actually, something that looks protective early in the menstrual cycle may be a risk factor later on. And the way that we think we can incorporate this into imaging is in a couple of different directions. So first, keeping with breast cancer and breast cancer epidemiology, the idea that we have is incorporating cycle day into analyses of mammography or digital breast tomosynthesis would give us some sense about whether or not the features that are being extracted vary over the course of the menstrual cycle. Another project that we're working on right now sort of is built on animal studies that show that symptoms of affective disorders like anxiety and depression in female mice are modulated by the menstrual cycle. And so here, if you're looking in human populations and you want to understand whether or not the menstrual cycle is affecting, say, the symptoms of anxiety or depression, you can do that, but also we're sort of thinking about and have submitted applications to get fMRI as well to understand whether or not the imaging features, the sort of network connectivity features, are mediating the effect of menstrual cycle on affective disorders at the outcome. So we're excited about that. And in the last minute or so that I have, I do want to talk a little bit about synergies with the School of Public Health. A lot of the things that folks have talked about up to this point, about community engagement, about ethics, but also on the research side, federated learning, artificial intelligence, other things like that. There's a lot of energy around that at the School of Public Health. But I think sort of more importantly, I want to emphasize translation. We sort of think very much about the discoveries that happen in a lab being translated to a clinical setting. Clinical interactions, you sort of look in aggregate, one here, one there, and pretty soon you're treating entire populations. And I sort of think about that sort of translational piece as an important component, to think not just about translation as affecting individual patient care, but to think about the translation into a clinical setting as shaping the health of populations. And so viewing this as an implementation science approach, understanding whether or not treatments are going to generalize, whether discoveries made in one clinical setting are going to be transportable in others. I think that's sort of the bread and butter of the kinds of things we think about in public health. So I'm excited to work with everybody and I'm thrilled to be here. Thanks very much. Questions? Questions? Thanks.
Thank you, Jeff. Thank you so much for your presentation and your energy in CIMBID. Rest assured, your p-values, your power calculation, there's nobody that can get them to you quicker and better than Jeff. Plus, also energize this amazing partnership with the Mailman School of Public Health. So thank you. And with that, I'd like to welcome another major partner in crime, Professor Lisa Konofahu, professor at the Department of Biomedical Engineering and Radiology and Associate Director of CIMBID, solidifying our relationship with engineering. Lisa, thank you.
Thank you so much, Despina. And I have to say I'm the less important Greek engineer in the room. So, and I say very briefly, because I know we're running out of time, that when I gave a talk at a workshop in Athens, in Greece, last year, and it was AI in medicine, and I asked you for a couple of slides on your work on MRI breast cancer. And after the talk, of course, there was a wildfire. It's July in Athens, that happens almost daily. And there was an evacuation, but there was a couple there. And one of them was actually a breast cancer patient who told me, can I just send you my MRIs and you tell me what my prognosis is? And she gave me a flower, which I never really have taken. So because of Despina's work, I get flowers after my presentation. So maybe today, no, it's a joke. But just to say that, it's a very impactful what Despina is trying to do here. And we're so happy that she's here organizing all of us, because I can speak for myself, I'm deeply disorganized. But the good news about Columbia is that, as the Dean mentioned, is that we have a lot of synergies, a lot of interdisciplinary, a lot of good people in what they do individually. So that's where we're going to be much bigger than the sum of our parts. So very briefly, I'm in ultrasound. As Sachin says, it's MRI with noise. And I'm so happy that you actually showed some ultrasound images today. So, and it's true that we have noise, but sometimes the noise, as we know, is actually the information that we're after. So as long as we have an idea of where our noise is, where our signal is, where the information is, sometimes the artifact is the information, sometimes the artifact is our noise. So it's very important to bring everything together. And in my group, we actually have also control over the data. So it's very important to not just use the imaging data as a black box and I don't know where it came from, but it's also to understand the data so that you can feed them in a model or you can feed it through whatever processing you do. So we bring together a lot of the ultrasound aspects, especially functional and anatomical. And then we do compare with MRI. We have also CT and PET that I'm going to show you. And the last part is actually you can use ultrasound for therapy, as some of you know. So first things first, we do a lot in the cardiovascular realm. We have developed 3 different imaging modalities within ultrasound where we can get the mechanical properties. One of them is called elastography. That is used actually quite a bit in cancer, but we use it for the heart to basically see where your heart, for example, will harden in the case of myocardial infarction or coronary artery disease. The one in the middle is something that we can actually, with a simple ultrasound, we can tell you where the arrhythmia may lie. Just by this wave that you see propagating contains information on the conduction. And the last one is, we call it pulse wave imaging, where on the aorta, as you see here, on the abdominal aorta, we can actually see the pulse propagating, and that contains information on a lot of on the pulse pressure, on the flow itself, and on the stiffness. So just because some of you are familiar with the just standard ultrasound, so we image the heart the way that it's done in the clinic, and then we get standard ultrasound images. Typically, there are different views. And that's what you see in the clinic. And then we have amazing cardiologists, actually on this campus, trying to pinpoint where the actual issue is, as far as ischemia, infarction, or arrhythmia. This is something that we still do by hand, so we should talk to Sachin about what we can do segmentation-wise. But then when you start processing these images, and we have thousands of frames per second, why? Because we have the speed of sound. And then we can see what is happening at very, very small milliseconds or even sub-milliseconds. And then we have very important processing that happens when we put them together. You can see activations of the heart on down to a micron, so 1,000 of a millimeter. And then when you start seeing all this information at large detail, then you can make a new map that is impossible to see by naked eye or by, unfortunately, the AI, because it's what you feed the AI. And then you can see red is activation of the heart in the middle, where the septum is, and the rest are the 2 ventricles. So we can do that in a standard ultrasound image. I'm going to skip this slide, but just to tell you the two views orthogonally throughout all the chambers in the heart. And then you can make a new map that's not available in the clinic right now, but you can pinpoint where ventricular contraction may be happening, in this case, on the red region, so that will be close to the apex. And then that particular patient had a paroxysmal arrhythmia. That means that it actually changes can change from one cardiac cycle to the other. And the second cardiac cycle, it went back to sinus rhythm, which is actually what you want. The heart is in harmony. The two ventricles are in sync. So we can map that with just a regular ultrasound. So imagine the wealth of this information that we can do with our signal processing techniques. We also actually apply also AI, but I'm not going to show AI models here because I feel the images speak much more by themselves. But then we want to actually integrate this in a typical clinical ultrasound scanner. Now, the other part of the cardiovascular system are the blood vessels, and ultrasound is doing a fantastic job at that, and it was mentioned stroke, and especially for the carotid that you see here on the left, where you're actually trying to see whether there's an obstruction by a atherosclerotic plaque, and our chair here does a lot of good work also with MRI on that. This is just a clean vessel, as they call it, and you can see the flow in the middle, but you can also see on each side what happens on the wall, the blood vessel. And then you can monitor that, and I mentioned earlier the stiffness that you can get on the wall at the same time as the flow, and get more of the pressure and how it changes, what feeds from the heart on the left to the brain on the right. Now, just a segue to say that we are also in cancer, and especially breast cancer imaging. We actually do use ultrasound in this case to probe the tissue. So as the wave propagates in the tissue, it actually knocks on the tissue. And then you can send waves and also understand more of the stiffness that you map in the middle. So blood orange is actually where the tumor is, and this lighter orange is actually where the parenchyma, non-cancerous parenchyma is. And after that, you can actually pinpoint the tumor and start ablating with regular ultrasound. So similar to laser, you can use those waves and increase the intensity until you burn. And we do have a clinical trial in breast cancer for non-metastatic tumors going on. I'm going to very quickly show you how we actually acquire all the signals, making sure that we get the raw data up there, the actual signals that come back at 1,000 frames a second, and then we can image the overall displacement or deformation of the tissue and make an image out of that in the middle, showing you where the softer region is in red versus blue around it. We build actually the actual scanner, again, research scanners that we actually have a robotic arm with specific parameters. And then we can actually now map the stiffness of the tumor, and we have what's called the displacement ratio up there, and how it changes in the case of chemotherapy. And within a couple of cycles, we can actually see whether that displacement ratio, DR, is actually increasing. That would be a good sign for the patient. In this case, it was a pathologic complete response. This is what you want to hear as a patient. This is when the actual tumor is actually responding to therapy. On the bottom is actually what the research sonograms look like. And what we are feeding this model is actually for segmentation. And we have a paper that I'm not going to show you today, but you can see the contrast that you have mechanically on top is much better than what a regular sonogram will show you. So that actually can pinpoint the breast tumor much better. So now I talked about all the imaging work, but I'm going to, in the segue where we actually use for thermal ablation in the tumor, we can lower the intensity and start doing very fun stuff in the brain. One of the bottlenecks in the brain is actually drug delivery. We have the blood-brain barrier as a structure that prevents most of the drugs to actually treat disease in the brain. So we pinpoint the hippocampus here, and this is MRI after gadolinium goes into the hippocampus, which normally it doesn't. And you see it lights up like a light bulb there. We apply this in Alzheimer's treatment and also Parkinson's in the middle, where we actually have some neurorestoration where the substantia nigra is. And we also use it for neuromodulation to drive the brain. I'm going to show you this as last slide. We use some gene editing here for gene delivery vectors that normally are on the order of several million actually Daltons, so they don't cross the barrier, so we're able to actually see some editing in the brain. And then we also have translated this to the clinic, as I mentioned, for Alzheimer's patients, where we actually use neuronavigation to pinpoint where the transducer will lie. And in amyloid PET, beta amyloid PET, we're able to see that where we have the actual vein here on the region where most of the amyloid is, we have a small reduction after a couple of weeks, and where the treatment is, and then the amyloid actually comes back because we haven't treated the brain further. The last slide is actually for pain modulation. So we use ultrasound to intercept in a modulatory fashion the pain that comes from carpal tunnel syndrome on the wrist all the way to the brain. We use EEG to see the difference that happens before and after interception of the signal. And we have found that we can actually get this pain sensation to decrease according to the intensity of the modulatory beam. So this is my last slide, and I'm going to use this for what happens when you have different departments come together, and especially like Despina said about undergraduate and graduates and postdocs. So I have a joint appointment in radiology and also have one in neurological surgery, and all these collaborators here and alumni from the lab were very important, but at the same time to see undergraduate high school students that we have in the summer, graduate students, postdoctoral fellows that come together, MD, PhD students, sorry to forget that, and they come together and it creates this, at the same time, engineering expertise, but also some basic, for example, biology, neuroscience, and then, of course, the medical clinical world and AI world. So that's something that we want to bring to the center, capitalize on that, and maybe organize this better as opposed to doing the ad hoc approach. And I don't know what that value would be. So thank you.
Thank you, Elisa, so much. You can see an example of research that goes all the way from hardware and instrumentation to trials and patient care. And I think this is captures, again, the essence of CIMBID. And speaking of students, in the new website that has launched today, there is a section for trainees. Anybody can reach out if they're interested to join a lab, attend lab meetings, join seminars, interested in doing a thesis, a project. They can connect directly with the center, and they can be linked through a very simple form with a PI that would be within their area of expertise from the CIMBID members to become engaged. So we're looking at organizing this a little bit. All right, so I will end this session by giving a little bit of an overview of related research in cancer. All right, here we go. All right. So putting on my investigator hat in my own lab, a lot of the research we do is leveraging artificial intelligence in cancer imaging for cancer applications. For the past 20 years or so, we've been working on developing both. I would say about 40% of what we do is develop the fundamental methodology. At the end of the day, we're computer scientists, engineers, so think about it as statistical approaches applied to three-dimensional, full-dimensional, and multidimensional spaces that imaging data represent. Pattern recognition and data science methodologies to investigate the role of imaging as a biomarker for personalized clinical decisions in cancer care. So as I said, about 40% of the work that we do is come up with the methods, the algorithms, to analyze the imaging data. And that's, most of the time, is, I would call it, is the basic science of what we do, develop the methodologies. Another 20% of our work, I would say, is develop fundamental methodology, but not just for imaging data. Take information from imaging data and link it, blend it with information from non-imaging data. Electronic health record, blood-based markers, I will show you, genetics, genomics, and other biomarker information. And the rest of the work that we do, about 40%, which I would say probably is the most fun and exciting work, is to work with everybody who's not a computer scientist. Nothing against computer scientists, love the computer scientists. But to work with clinicians, epidemiologists, statisticians, engineers, oncologists, primary care physicians, geneticists, and investigators across the domain, basic science, translational and clinical science, to evaluate these algorithms and methodologies on a population level, both retrospectively, prospectively, in the context of clinical trials as well. The way we see cancer care is in three different separate areas: screening and prevention, prognosis, and treatment. And as an investigator, I'm not necessarily interested to diagnose what's there. I leave that to my very wonderful colleagues here in the room. But again, what I'm really excited about is to predict what will happen in the future and what value can imaging bring into that insight, and what are the implications of those insights. So in the area of screening and prevention, I'll show here a lot of examples from breast and lung cancer imaging, which is an area that we've worked on in most of my career so far, but we're very actively expanding here at Columbia in ovarian cancer, pancreatic cancer, and other cancers that we want to address as well. So in the area of screening and prevention, in breast cancer, important question is, how do we screen women? What's the appropriate personalized screening scenario? What are appropriate risk-reducing interventions? And a very important decision point and insight in this planning is who is at high risk of breast cancer, who's at low risk of breast cancer. And I'm sure that at least most of the women in the room have heard about the importance of mammographic density, how it implicates both the sensitivity and specificity of mammography, but it's also an independent risk factor for breast cancer for women, and how important it is to be able to measure that it's actually a federal law at this point that mandates that this information needs to be reported to every woman at the time of screening, and there needs to be some implication and discussion around what does this mean, what the risk of breast cancer is, and how that implicates screening and prevention. So some of our earlier work focused on developing fully automated methods, this is the basic science of what we do, to measure mammographic density from all kinds of images, from 2D mammograms, 3D mammograms, MRI, ultrasound. I'm not showing that here. We've done some ultrasound, Elisa, and create the fundamental methodology. And some of our work now is evolving, especially using artificial intelligence, both how to measure some of that information, breast density, but also go beyond just the information of mammographic density, which is a simple percent, to the overall parenchymal pattern and structure of the breast. How does that relate to breast cancer risk? Can we use artificial intelligence to go beyond what we can just see with a bare eye and the concept of density? We actually just had a study that was published in Radiology with more than 40,000 women, where we looked at 2D mammograms, and we were able to characterize parenchymal patterns of the breast and intrinsic phenotypes that were associated with the risk of developing breast cancer in the future, above and beyond just breast density and the conventional demographic information. So how do we build these models? How do we use AI to make these models more precise, to integrate more information from imaging, electronic health record, genetics is a major area of interest, and how do we bring those models into the clinic to personalize the screening approach and guide risk-reducing interventions? In the second area, prognostic assessment, assume you have a cancer, we want to use information from imaging and non-imaging data to determine how aggressive the disease is, how likely it is to recur, what's the timeline of the recurrence, is there likely that any genetic mutations exist or will develop in the future, and how does implicate therapy. And a phenomenon that we're very, very interested in is the phenomenon of tumor heterogeneity. We now recognize that cancer is a heterogeneous disease, not across individuals, but within the same tumor. And so the conventional approach of biopsying a tumor is very limited in capturing that heterogeneity, the spatial heterogeneity of the disease. We have liquid biopsies, that aim to capture some of that through blood-based testing, but still the sensitivity is not quite high for all types of cancers, and the spatial phenomenon of heterogeneity is also not captured by these assays as well. In my view, imaging is the only modality that can capture tumor heterogeneity in vivo. The question is, we see the heterogeneity, we don't know how to interpret it. And I think this is an area that AI can help us a lot moving forward. So we've developed approaches. Again, the basic science of what we do is to develop all the algorithms to do this automatically, find the cancer in the scan, automate the delineation, so we can get information such as tumor volume, longest diameter of the tumor, speculation, and then start looking at the inside and quantifying the heterogeneity. I will have to say that I have a certain thing for the longest tumor diameter. If you're in the field of oncology, you know that longest diameter is one of the most important metrics used to determine if a patient is responding to therapy. The idea is, did the tumor expand or did it shrink? And the longest diameter of the tumor is measured from imaging to capture that information. And based on that information, the oncologist determines whether or not, for example, to continue a certain therapy, whether or not to add another therapy, and with conjunction with other data. When I was a grad student, I was shadowing a radiologist as part of my thesis. And I literally saw the radiologist measuring the longest diameter by taking the mouse and clicking in the image. And my mind was blown away. That was the moment that I decided I wanted to live in a medical center. Because I said, what are we doing here? We have like hundreds of publications talking about fully automated segmentation methods. And here we have a radiologist. And again, think about a three-dimensional scan. So 100 slices, going through them and eyeballing, trying to find what's the longest diameter. And that's how they still do it today. My mind is still blown by this. So when you do an oncologic study, you have to budget the radiologist's effort to do the infamous resist measurement, right? So these are some of the barriers we want to alleviate and fully automate, and we have all the tools to easily do that. And so how do we extract information from imaging data, especially multidimensional information? The heat map that you see there, I see a lot of folks in the room involved with bioinformatics and genetics and genomic studies, is actually generated from imaging measurements, imaging features, so longest diameter, speculation, textural parameters, vascularity, and so forth. We call them radiomics. It was mentioned by some of my colleagues before. Sometimes people ask me, what are radiomics? Well, I say radiomics is when radiologists decided we also had to have something that ended in omics to be relevant, right? But in principle is the extraction of high throughput information from imaging data in a very similar manner that a lot of the other assays do, like RNA sequencing and so forth. So you end up with features, with a feature vector, with a signature that comes out of imaging data. And you can use bioinformatics techniques to quantify, characterize, analyze that data, try to see if you have intrinsic phenotypes of heterogeneity through imaging. And our studies consistently show that that type of information is very relevant in prognostication, in characterizing the disease and how it will behave in the future. So we've done a lot of work in lung cancer across these lines, trying to extract signatures that predict response to immunotherapy, targeted therapy, taking a step further, blend that information with information from liquid biopsy data. This is a very exciting study that we're kind of trying to wrap up. I think it's going to make a very nice publication. These were just some of the preliminary publications where we looked at combining liquid biopsy data with imaging phenotypes from CT scans for lung tumors to be able to predict response and targeted therapy. We're trying to do that also in the setting of screening and lung nodules. Can we combine information from lung nodules with liquid biopsy to avoid biopsying the cancer? Why is this so important? For example, in certain cancers, like breast cancer, I see here Dr. Pinker, she does a lot of biopsies, I know. It's uncomfortable, it's not the best thing to do in your day, but at the end of the day, it's a very easy biopsy. In certain other diseases like lung or brain, the biopsy could even kill the patient. So if you know, like in the example of lung nodules, you have a very low yield of a positive biopsy, you don't want to be throwing that around just for any reason. So if we can have a non-invasive approach from imaging and liquid biopsy data, I call liquid biopsy non-invasive because it's very limited and, getting a blood draw, unless you're my son, where you think like giving like blood is like the worst thing that can happen to you because he's 9 years old, but I'm sure we can all handle that. Putting that information together can provide a non-invasive approach and be very useful clinically. And the third area, the therapy response evaluation. During the course of therapy, we can use artificial intelligence not to get a snapshot of the tumor heterogeneity at baseline, which is very important, but to see also how that changes over time and if there's de novo heterogeneity developing in the tumor. Now, why is it important that we all come together? Because I can tell you if the heterogeneity is changing, but I have no idea what that means. But if we come together and put information, let's say from digital pathology, spatial transcriptomics, and do those studies that map the macroscopic imaging that we get from radiological scans that are routinely collected and reimbursed through insurance, with some of the more spatial omic data that are more expensive, and as much as we love them, we'll never make them a day-to-day thing in the clinic, we can maybe even potentially derive virtual biopsies that could capture the information about cancer for the entire tumor. That's what makes me the most excited, I think, in this age in my own research and in my lab. And then use AI to integrate data longitudinally from scans, from the EHR, from other assays, to be able to have longitudinal phenotypes and predict outcome of diseases. This was a study on COVID, for example. We wanted to predict what will happen to patients who were admitted in the clinic, if they're going to end up in the ICU, if they're going to die from it, or so forth. And this is a prime example that why I also keep emphasizing that infrastructure to do this research is so important. When we started this study, we had to build that cohort institutionally, get the longitudinal scans, get the EHR data. That was COVID times, right? We got funding in the beginning of the pandemic. We all wanted to get there. But the time we built the cohort, and did the study, it was almost a year or two afterwards. You only needed one variable to say if the patient can die or not, and that was vaccination. Nobody cared about the imaging data anymore or the other information or so forth. That one variable could beat any neural network that we build in the meantime. And so having the infrastructure, the platform, the computing power, the ease of access to data is super important to bring these technologies to life and to translate them in the clinic. And I would like to close with acknowledging all the lab members for their phenomenal work, trainees across the board, from undergraduate to graduate to postdocs, wonderful collaborators, and would love to keep making that list longer and longer and include everybody who would love to work with us here at Columbia University. So thank you so much. I'm happy to answer any questions, but if you're super hungry, we can also jump straight to lunch. Thank you.